The investigation of hyperthyroidism. Welcome to our deep dive on the investigations used to establish a diagnosis of hyperthyroidism, presented in a structured, podcast-style format tailored for our audience of clinicians, students, and health enthusiasts. Today, we'll walk through the logical steps a practitioner would take, from the initial suspicion all the way to pinpointing the underlying cause. Step 1. Clinical assessment. Laying the foundation. The journey begins, as always, with a thorough clinical assessment. Before any laboratory investigations are considered, the clinician focuses on a detailed history and comprehensive physical examination. In the history, key symptoms pointing towards hyperthyroidism include unexplained weight loss despite increased appetite, palpitations, feelings of nervousness or anxiety, heat intolerance, excessive sweating, tremors, fatigue, and changes in bowel habits such as more frequent movements. For women, disruptions in the menstrual cycle may also be noted. On physical examination, some classic signs may surface: a rapid heart rate or irregular rhythm such as atrial fibrillation, a fine tremor of the hands, skin that is warm and moist to the touch, and features like lid lag or retraction, resulting in a characteristic staring appearance. In Graves' disease specifically, additional findings such as bulging eyes, what we call ophthalmopathy, and pretibial myxedema, a distinctive skin change on the shins, may be present. The goal at this stage is to raise a well-founded clinical suspicion of hyperthyroidism, which will then require confirmation through laboratory tests. Step 2. Biochemical investigations. Confirming the diagnosis. The next step is the biochemical confirmation of hyperthyroidism. This involves blood tests that assess the levels of thyroid hormones and the hormone produced by the pituitary gland to regulate the thyroid. The first test ordered is the thyroid-stimulating hormone. This is the most sensitive marker for thyroid dysfunction. In primary hyperthyroidism, meaning the thyroid gland itself is overactive, the elevated levels of thyroxine and triiodothyronine suppress the production of thyroid-stimulating hormone by the pituitary gland. Therefore, a low or undetectable thyroid-stimulating hormone strongly suggests hyperthyroidism. Next, the clinician measures the concentrations of free thyroxine and free triiodothyronine. These are the active forms of thyroid hormones in the bloodstream and are not influenced by variations in binding proteins. In overt hyperthyroidism, both the thyroid-stimulating hormone is low and the free hormone levels are high. There are cases, such as early Graves' disease or when a toxic nodule is present, where only the free triiodothyronine is elevated, making this test particularly valuable. In subclinical hyperthyroidism, the thyroid-stimulating hormone is low while both free hormones remain within normal ranges. This milder form may not produce obvious symptoms but signals that the thyroid gland is beginning to malfunction. The pattern of these test results helps the clinician interpret the findings. A low thyroid-stimulating hormone with high free hormone levels confirms overt primary hyperthyroidism, while a low thyroid-stimulating hormone with normal free hormone concentrations points to the subclinical form. If the thyroid-stimulating hormone is normal or high but the free hormone levels are elevated, this suggests a much rarer scenario, such as a pituitary gland disorder. Step 3. Determining the underlying cause. The etiology. Once hyperthyroidism is established biochemically, the next phase is to determine its cause, as this guides long-term management. The starting point here is the thyroid autoantibody panel. Among these, the most definitive are the antibodies directed against the thyroid-stimulating hormone receptor. These are responsible for stimulating the thyroid gland in Graves' disease, leading to autonomous hormone overproduction. A positive result for these antibodies is highly specific for Graves' disease. There are two principal laboratory methods for detecting them. One measures whether antibodies can bind to the receptor, and the other tests whether they actually stimulate the receptor, the latter being more specific. Other autoantibodies, such as those against thyroid peroxidase and thyroglobulin, are nonspecific indicators of thyroid autoimmunity. They often appear in Graves' disease but are also common in Hashimoto's thyroiditis, so they support, but do not confirm, an autoimmune cause. The next tool is thyroid ultrasound, which provides both structural and functional insights. In Graves' disease, ultrasound typically reveals a diffusely enlarged gland that appears darker on imaging, with increased blood flow, a phenomenon known as thyroid inferno. Ultrasound is also critical for detecting single or multiple nodules, as seen in toxic adenoma or toxic multinodular goiter, and can help characterize the appearance and vascularity of the gland in cases of thyroiditis. If the cause remains unclear after antibody testing and ultrasound, the radioactive iodine uptake scan becomes invaluable. This functional assessment measures the thyroid's ability to absorb iodine, a crucial element in hormone synthesis. The patient ingests a small dose of radioactive iodine, and specialized imaging quantifies the uptake at set intervals. The pattern provides diagnostic clues. Diffusely high uptake characterizes Graves' disease, while focal high uptake with suppression elsewhere identifies a toxic adenoma. If multiple areas are overactive, toxic multinodular goiter is likely. Critically, very low or absent uptake suggests that the gland is not actively producing hormone but is instead releasing stored hormone, as occurs in thyroiditis, following excessive iodine intake, or in cases of deliberate thyroid hormone ingestion. Bringing it all together, a diagnostic algorithm to summarize. The diagnostic journey for hyperthyroidism unfolds as follows. First, the clinician builds clinical suspicion based on symptoms and signs. Next, they confirm the diagnosis with laboratory tests, focusing on thyroid-stimulating hormone and free hormone levels. If these confirm overt or subclinical hyperthyroidism, the next step is to establish the underlying cause. The search begins with thyroid-stimulating hormone receptor antibodies to diagnose Graves' disease. If this is inconclusive, thyroid ultrasound is used to investigate structural changes or nodules. Finally, the radioactive iodine uptake scan helps differentiate between high uptake conditions, such as Graves' disease and toxic nodules, and low uptake states, such as thyroiditis, especially when the ultrasound does not provide a clear answer. Additional supportive investigations. Other investigations support the overall evaluation and management plan. An electrocardiogram is important for detecting heart rhythm disturbances like atrial fibrillation, a common complication of hyperthyroidism. A complete blood count may reveal mild anemia or increased lymphocyte counts. Liver function and calcium levels are also checked, especially before starting medications that may affect the liver, and to screen for the rare occurrence of elevated calcium. Conclusion. In conclusion, diagnosing hyperthyroidism is a methodical process that starts with clinical suspicion, proceeds to biochemical confirmation, and culminates in investigations to determine the specific cause. This structured approach ensures that patients receive an accurate diagnosis and tailored, cause-specific treatment. Thank you for joining us on this episode of the Everything Surgery podcast, where we dissect the extraordinary. If you appreciate our content, please like, share, and subscribe to stay updated on our latest episodes.